Welcome to CPT Coding Guidelines Review for Echocardiography. Achieving accurate and complete coding is the purpose of coding guidelines. However, you can't take advantage of the benefit of having guidelines if you don't know what direction they provide. Even if you don't know the specifics of a guideline, just being aware that guidance is available for a particular situation is valuable. This series is designed to help you become better acquainted with often unfamiliar CPT guidelines for coding of significant procedures, with the intent of making you aware that the guidance exists to ultimately improve coding proficiency and boost confidence in your ability to code these procedures. The guidelines are waiting, so let's get started. Knowing something about the objective of a procedure and/or how the procedure is performed always promotes understanding of the direction given in the guidelines. This installment of CPT Coding Guidelines Review covers the guidelines for coding echocardiograms. So, before we dive into the guidelines themselves, let's take a quick look at what echocardiography is. Echocardiography uses sound waves to create real-time imaging of the heart. The images created show how blood flows through the heart chambers and valves. This procedure may also be called a heart ultrasound or heart sonogram. Echocardiograms can produce both 2D and 3D images. Doppler signals help measure speed and direction of blood flow. Color flow imaging is also used to indicate flow. There are 4 common types of echocardiograms: transthoracic, transesophageal, stress, and fetal. Fetal echocardiography is reported from the radiology section of CPT rather than the medicine section, so the guidelines for this type of echocardiogram are not covered in this presentation. If you're interested in learning more about each type of echocardiogram, please visit the website at the URL shown here. A complete transthoracic echocardiogram with spectral and color flow Doppler is reported with code 93306. Without spectral or color flow Doppler, the study is reported with code 93307. This procedure is a comprehensive 2D and select M-mode examination of several cardiac structures, including the right and left atria, right and left ventricles, the aortic, mitral, and tricuspid valves, and the pericardium and adjacent aorta. M-mode imaging is one-dimensional imaging used for very fine measurements by focusing on only one line of the 2D image. Multiple views are required to obtain a complete functional and anatomic evaluation. From these views, measurements are obtained and recorded. Even with significant effort, some structures may not be able to be visualized. When this is the case, the reason why an element was not visualized must be documented. Visualization of additional structures, such as the pulmonary vein, artery, or valve, or the vena cava, are included and not separately reportable. A follow-up or limited echocardiogram is reported with code 93308 and does not evaluate or document an attempt to evaluate all the structures that comprise a complete echocardiographic study. This type of exam is usually limited to or performed in follow-up of a focused clinical concern. During stress echocardiography, images are recorded from multiple cardiac windows before, after, and in some protocols during stress. Stress is achieved by walking on a treadmill, using a supine or upright bicycle, or through the administration of pharmacological agents that either simulate exercise by increasing heart rate, blood pressure, or myocardial contractility, or that alter coronary flow. The patient's electrocardiogram, heart rate, and blood pressure are monitored throughout the procedure and the recovery. Reports are prepared from the results to evaluate the duration of stress, the reason for stopping, and the hemodynamic response to stress, as well as the electrocardiographic response to stress and the echocardiographic response to stress. As we saw in the previous slide, a stress echo includes two components, both a stress test, which involves stressing the heart and then monitoring its electrical function with an electrocardiogram, as well as an echocardiogram, which involves imaging the heart's function in relation to blood flow and contractility. In some cases, both components of the stress echo may be performed by the same physician, but in some cases, different physicians may perform only certain parts of the study. Additionally, how much of the test a physician provides will depend on whether the procedure is performed in the physician's office or a facility. CPT has guidelines around code assignment that address these differences. When not all of the professional services of the stress test are performed by the same physician performing the stress echo, assign code 93350 for the echo in conjunction with the appropriate codes from the range of 93016 to 93018 for the components of the stress test provided. When the same physician performs a stress echo with a complete cardiovascular stress test, including continuous ECG monitoring, supervision, interpretation, and report, assign code 93351. When only the professional components of a complete stress test and stress echo are provided, such as in the facility setting, by the same physician or other qualified healthcare professional, assign code 93351 with a 26 modifier. If left ventricular borders cannot be adequately imaged with standard echocardiographic technique, IV echocardiographic contrast may be infused both during stress and at rest to achieve this purpose. Code 93352 is assigned to report the administration of echocardiographic contrast agent in conjunction with stress echo codes 93350 or 93351. Supply of the contrast agent and/or pharmacological stress agents may be reported separately. Code 93355 is used to report transesophageal echocardiography services during transcatheter intracardiac therapies. Code 93355 is reported once per intervention and only by an individual who is not performing the interventional procedure. Code 93355 includes the work of passing the endoscopic ultrasound transducer through the mouth into the esophagus when performed by the individual performing the echocardiogram, diagnostic transesophageal echocardiography, ongoing manipulation of the transducer to guide sizing and/or placement of implants, determination of adequacy of the intervention, and assessment for potential complications. Real-time image acquisition, measurements, and interpretation of images, documentation of completion of the intervention, and final written report are included in this code. Code 93355 describes transesophageal echocardiography during advanced transcatheter structural heart procedures, such as transcatheter aortic valve replacement, left atrial appendage closure, or percutaneous mitral valve repair. See 93313 for separate insertion of probe by a physician other than the physician performing the transesophageal echocardiogram. Report of an echocardiographic study, whether complete or limited, includes an interpretation of all obtained information, documentation of all clinically relevant findings, including quantitative measurements obtained, plus a description of any recognized abnormalities. Pertinent images, videotape, and/or digital data are archived for permanent storage and are available for subsequent review. Use of echocardiography not meeting these criteria or without thorough evaluation of organs or anatomic region, image documentation, and final written report is not separately reportable. Thanks for watching. Health Information Associates is committed to providing educational products that help coders to be their best. So be sure to check out the other presentations in the CPT Coding Guidelines Review series, as well as our full catalog of courses at hialearn.com.